Let me introduce myself as Dr. Manoraajan. I'm basically a nephrologist into this field of PG entrance exam training for the past 15 years with a special inclination towards Harrison-based teaching. There are few topics in medicine which we can call morale boosters as far as entrance exam is concerned. If the questions from those topics are answered confidently, the confidence level in the exam hall becomes tremendously high, and this rubs into the other subjects, and your performance might increase by more than 10%, and those 10% might bring you success. What are those topics? Sample topics are questions based on acid-base balance, questions based on SPM statistics, and a topic called as congenital adrenal hyperplasia. So today we have chosen one topic, CAH, and we'll discuss regarding that and see some questions which have been asked in the previous entrance examinations. So before going into CAH, I just want you to look into the slide and please tell me the color, not the word. For example, the first one is green, second one is blue, red, third one is blue, fourth one is yellow, and fifth one is blue. What is it called as? This can be called as a brain teaser. Brain teaser is one which can remove the shackles in your neurons and make you interact. So every discussion will start with the slide called as brain teaser. For example, if you are discussing CAH, the slide will have a brain teaser like this. Suppose if you are with us for physical classroom sessions, we would have asked you to interact. At least go through this kindly. And at the end of the session also, I'll show the same slide. So when you see this, you will be in a position to answer all these brain teasers after the discussion. Now we'll jump into the main topic, CAH. First, why it is called CAH? The main crux in the CAH is decrease in the hormone production in aldosterone. Once the hormones is cut off, the control mechanism ACTH is increased, and this causes hyperplasia of the glands, so there is CAH. Basic pathology is decrease in the secretion of various hormones from the adrenals. So to know that, we should know exactly what is the pathophysiology of the hormone production from the adrenal gland. We know there are three layers: glomerulosa, fasciculata, and reticularis. Glomerulosa secretes a hormone, most important hormone, aldosterone. Fasciculata, the next hormone, cortisol, which is a glucocorticoid. Zona reticularis secretes androgen, which is a sex steroid. So three hormones, but there are four important enzymes which takes part in this pathway, and once they are deficient, this leads to CAH. Now we'll jump into the enzymes which take part in this program. There are four enzymes. We'll see the commonest and the most important enzyme in CAH. This enzyme is called as 21-alpha hydroxylase. It takes part in two hormone production, aldosterone and cortisol. The second enzyme is called as 11-beta hydroxylase. This also takes part in two hormone production, namely aldosterone and cortisol. The third hormone is 17-alpha hydroxylase. This takes part mainly in one hormone production. Predominantly, it is your so-called, this takes part in cortisol and your so-called dihydrotestosterone. The last hormone is 3-beta hydroxysteroid. This is the only enzyme which takes part in all three pathways. So 4 hormones and different clinical presentations. To summarize, the 4 enzymes are 21-alpha hydroxylase, the commonest, chromosome 6. The rarest is 3-beta hydroxysteroid dehydrogenase. As we know, any genetic disorder which is based on enzyme is predominantly autosomal recessive. All CAH variants are autosomal recessively transmitted. Now we'll see 2 important hormones which controls the outline of CAH. The first hormone is aldosterone. So we should know the crux of function of aldosterone. As we all know, aldosterone acts on your epithelial sodium channel. When this is stimulated, it acts to increase your sodium absorption. Sodium being a positive ion, once it is absorbed, it tries to chuck out the other positive ions, namely K plus and H plus. So when there is increased aldosterone, when increased aldosterone is there, there is increased sodium causing hypernatremia, there is decreased potassium causing hypokalemia, and there is decreased H plus causing metabolic alkalosis. This is the crux of any hyperaldosteronic state. Now we'll see what happens to the clinical presentation. When there is excess aldosterone, it is called as salt retention. And as we all know, when there is salt retention, naturally blood pressure shoots up and they are called as hypertensives. So this variant of CAH, in any condition in which there is increased aldosterone, comes under a hypertensive variant. Now to summarize, increased aldosterone, clinically they are called as hypertensives. Biochemically, you should know the complete profile. Because of salt retention, hypernatremia. Because K plus is chucked out, there is hypokalemia. Because H plus is also pushed out, there is metabolic alkalosis. Because of sodium retention, hypertension. When there is excess aldosterone, it sends a negative feedback and suppresses your renin. This is the complete profile of increased in aldosterone. Now we'll see what happens when there is decreased aldosterone. When there is decreased aldosterone, the patient is called as a salt waster. When you waste salt, you lose sodium, so naturally there is hyponatremia. Then potassium is retained, it causes hyperkalemia. H plus is again retained, it causes metabolic acidosis. They are called as salt wasters. Since aldosterone is low, there is compensatory increase in renin, and these patients will have high renin. Now we'll go to the next hormone, which dictates the external makeup of a fetus, testosterone. Testosterone, we know it is required for two functions. One, for the genital development. Two, it is required for the secondary sexual characters. When we see this point here, testosterone, we'll see what happens when there is excess testosterone in the fetus. First, we'll look into your male fetus. Male fetus, when there is excess testosterone, it will be normal at birth, not much alteration apart from just excess hyperpigmentation of the genitalia. But in later life, when there is excess testosterone, what happens? The child becomes like this. What is that? This is your precocious puberty. So when there's excess testosterone in the fetus, in a male child, the child becomes a precocious puberty child. Now we'll see what happens when there is a more testosterone in a female fetus. When there's more testosterone in a female fetus, this alters the genital makeup. The clitoris gets hypertrophied and this patient looks like a male. What is it called as? They are called as virilizers or ambiguous genitalia in a female child. They present with the clitomegaly. Now we'll see what happens in a male fetus when there is no testosterone. Male fetus, no testosterone. What happens? As we know, testosterone is required for the genital development. When there is no testosterone, the male fetus has hypogonadism. In that very small phallus, testes might not be descended, and this is called as ambiguous genitalia at birth in a male child. This is how they present male child ambiguous genitalia. Now we'll see what happens to a female fetus when there is no testosterone. Normally, in a female fetus, testosterone is not required. So its absence does not make any change. When there's no testosterone in a female fetus, the child comes out normal female child. To summarize the effect of testosterone, more testosterone is called as virilizers. In male child, it leads to precocious puberty. In female child, it causes ambiguous genitalia. Now we'll see what is the effect of less testosterone. When there is no testosterone, in male child, it is hypogonadism or ambiguous genitalia at birth. In a female child, it is plump normal phenotypic makeup. Now we'll go into the crux of CAH as far as entrance exams are concerned. In any entrance exam, they generally ask regarding the what happens when the enzyme is lost, which hormone is low, which hormone is high, what is the biochemical marker for diagnosis, and what is the clinical presentation in a male child and a female child. This is the pattern they ask in the entrance exams regarding CAH. Regarding biochemical marker, 1 point. The immediate biochemical marker product just above the enzyme which is deficient is considered as the biochemical marker for diagnosis. So for each enzyme, the biochemical marker differs. Now we jump into the commonest enzyme, 21-alpha hydroxylase deficiency. This is the commonest enzyme which is deficient. We'll see in which pathway this takes part. As we see here, this 21-alpha hydroxylase takes part in two pathways. One, aldosterone, two, cortisol. So when 21-alpha hydroxylase is deficient, two enzymes are not produced, namely no aldosterone, no cortisol. The crux of CAH is when one pathway is cut off, the byproduct is channelized into the other product and that gets elevated. So there is increase in androgen. So what happens here? There is decreased aldosterone, decreased cortisol. Cortisol, for discussion's sake, it won't make much difference. So forget cortisol, just please concentrate on aldosterone and androgens. So when there's low aldosterone, they are called as we discussed, they are called as salt wasters. When there's excess androgen, they're called as virilizers. So now we'll see what happens in a female child and male child in 21-alpha hydroxylase deficiency. Before that, we should know what is the biochemical marker for diagnosis. As we discussed, the immediate biochemical product which is just about the enzyme which is deficient, namely 17-hydroxyprogesterone, is the biochemical marker for CAH, 21-alpha hydroxylase deficiency. Little more details regarding 21-alpha hydroxylase. So as we saw, this is the place where it acts on no aldosterone, no cortisol, salt waster, and then there will be increased testosterone, so virilizers. We'll see what happens in a male child and a female child. Both in a male child and female child, they are salt wasters. In a female child, as we discussed, they present enlarged clitoris that is called as ambiguous genitalia at birth. In a male child, the only clue at birth will be subtle hyperpigmentation. It will be only subtle hyperpigmentation. Later life, they come with florid precocious puberty. This is your 21-alpha hydroxylase deficiency. Now, I'll be glad if you can fill up the blanks to assess how far we have assimilated. What hormone will be low? What will be high? What is the biochemical marker? What is the clinical presentation? What is the female in a male and a female in a 21-alpha hydroxylase? Please answer. We'll see what will be the hormone will be low. As we discussed, no aldosterone, so salt wasters. What hormone is high? We discussed it is testosterone, so they're called as virilizers. What is the biochemical product we saw which will be there? The immediate precursor product, as we discussed, it is 17-OHP. To summarize CAH, hormones low aldosterone, so salt wasters. Hormones high testosterone, so virilizers. Clinical presentation, female ambiguous genitalia, male precursor puberty. The biochemical marker is 17-OHP. This is your 21-alpha hydroxylase deficiency. And biochemical profile, if you want to put the biochemical profile, since they are salt wasters, they have hyponatremia, hyperkalemia, metabolic acidosis, and since there is aldosterone level is low, renin becomes high. This is the point regarding 21-alpha hydroxylase deficiency. They present with shock in the newborn period. Now we jump into the next enzyme, 11-beta hydroxylase. Please look at this. So when you look at this enzyme also takes part in two pathways. One, aldosterone, two, cortisol. So when this is cut off, no aldosterone, no cortisol. So naturally, what is the enzyme what is the hormone which is elevated? That is testosterone. So increased testosterone, low aldosterone. Then immediately the question arises, is it similar to 21-alpha hydroxylase deficiency? I just wanted to please concentrate here. There's a mild and important difference here. 21-alpha hydroxylase took part in a step little higher than the 11-beta. When 11-beta is lost, there is one more product which accumulates, which is a refined product which can act like hydrocortisone, act like aldosterone. So even though there is less aldosterone, there is elevated deoxycorticosterone, and this acts like an aldosterone. So they act like hyperaldosteronic state. When there is excess aldosterone, we saw they behave like a hypertensive variant. There won't be any salt wasting. They come under a hypertensive variant. Next question they ask, what will be the biochemical marker to diagnose 11-beta hydroxylase deficiency? Please look in the slide. As we discussed, the immediate biochemical precursor. Here there are two precursors, deoxycorticosterone and 11-deoxycortisol. But for all practical purposes, the biochemical marker becomes 11-deoxycortisol. This is increased in 11-beta hydroxylase deficiency. So to diagnose 11-beta hydroxylase deficiency, you should ask for 11-deoxycortisol, not 17-OHP. Fine. Now we'll see what will happen in a male child, what will happen in a female child. The same thing we discussed in 21-alpha hydroxylase. When there is excess testosterone in a male child, it will present with your precox puberty. Female child, ambiguous genitalia at birth. Now, this is your 11-beta hydroxylase. Kindly fill in the blanks. What hormones will be low? We saw aldosterone will be low, but most importantly, testosterone is high, and corticosterone, which acts like aldosterone, so they come under a hypertensive variant. The biochemical marker we saw, it is 11-deoxycortisol. Clinical presentation, same like so-called 21-alpha hydroxylase, precox puberty in males and ambiguous genitalia in females. Main difference, this presents with hypertension, does not have salt esters. And now we know, since this presents with hypertension, we'll just recollect the complete biochemical profile of 11-beta hydroxylase. Excess aldosterone, so hypernatremia, hypokalemia, metabolic alkalosis, and there will be decrease in your renin level. This is the point regarding 11-beta hydroxylase deficiency. Now we'll go into the next enzyme, 17-alpha hydroxylase. This enzyme, as we know, takes part in this pathway. So once this enzyme is deficient, 17-alpha deficient, two hormones will not come in. What are they? One, cortisol, two, testosterone. What hormone will come in? The hormone which comes in is aldosterone. So they act like increased aldosterone, so hypertensive variant, less testosterone. As we discussed, when there's no testosterone, in a female child, there will be no difference. Phenotypically, normal female. In a male child, when there is less testosterone, as we discussed, there will be hypogonadism and ambiguous genitalia at birth. What is the immediate precursor which acts as the biochemical marker for 17-alpha hydroxylase? Kindly look at this picture, and this is your pregnenolone. This acts as the marker for your 17-alpha hydroxylase deficiency. So now we'll look into the 17-alpha hydroxylase deficiency. What hormone will be low? As we saw, two hormones will not come in. They are cortisol and testosterone. What hormone will be high? There will be aldosterone. So they are called as hypertensive variant. The biochemical product is pregnenolone. Male child presents with your ambiguous genitalia. Female child, normal appearance. So this is your 17-alpha hydroxylase deficiency. Now we'll go into the final enzyme, 3-beta hydroxysteroid dehydrogenase. This is the rarest one, so very rarely asked in examinations. I'll spend few seconds here. One, I want to impress. This is the only enzyme which takes part in all three pathways. So when this enzyme is deficient, all three hormones, namely aldosterone, cortisol, and dihydrotestosterone are lost. So presentation wise, I'll just give only 1 point for you to remember. This patient will present with the salt wasting variant and ambiguous genitalia in both sexes. Rarely they might ask this. Ambiguous genitalia in both sexes occurs in only one enzyme deficiency, and this is your 3-beta hydroxysteroid dehydrogenase deficiency. Now, there are three methods by which they present. One, virilizes when there is excess testosterone. Two, hypertensives when there is excess aldosterone. Salt wasters when there is no aldosterone. So virilizers, we saw two enzyme deficiency causes virilization. What are they? 21-alpha hydroxylase and 11-beta. Salt wasters, we saw the first enzyme is 21-alpha hydroxylase, is a salt waster, and the last uncommon enzyme is also a salt waster, in which both of them will not have your aldosterone. The third variant is hypertensives. Hypertensives, these are the two enzyme deficiencies which causes hypertension. 17-alpha because of increase in aldosterone. 11-beta, as we discussed, it is not because of increase in aldosterone, but because of increasing your so-called corticosterone. This is the point regarding your so-called 11-beta hydroxylase. Now, this was the first slide we put in when we started the discussion. Now you should be in a position to answer most of that. So as we saw, the first point is autosomal recessive, chromosome 6, salt wasters are 21 and so-called 3 beta. Hypertension is 11 beta and 17 alpha. The most important, the commonest product which is asked in the exam for diagnosis is your 17 OHP. This is the point regarding this. This slide completely fills your entrance exam oriented discussion for your CAH. Ambient genitalia in females, this is your 21 alpha hydroxylase and 11 beta. Ambient genitalia in male occurs in only one enzyme, that is your 17 alpha plus 3 beta hydroxy also. Now we'll go into your antenatal diagnosis. Suppose a person comes with a history of CAH in the prior pregnancy. To confirm whether this fetus also has the same disorder, the commonest marker they assess in the fetus is your 17 OHP. If it is elevated, they consider that this patient has a CAH. Now we should know the management. How to treat the child after delivery and how to treat the mother before delivery. So what will happen after delivery? Once the child is born, it is very simple. You have to supplement the hormones. The hormones which are decreased, for example, if the aldosterone is low, give fluorocortisone. If there is low cortisol, treat with your hydrocortisone. Later life, when there is excess androgen, you have to knock it out with an anti-androgen flutamide. So the commonest treatment, if they ask, it is hydrocortisone for the child. What is the treatment of choice for the mother? Mother, as soon as the pregnancy is diagnosed, please, you have to start with your dexamethasone. This is the treatment of choice for a mother who had history of CAH in the prior pregnancy. Now we'll go into the firing round. Firing round contains questions which have been asked from the previous examinations pertaining to CAH. Now we'll see how far the discussion was relevant towards entrance examinations. First question, most common enzyme deficiency in CAH. We discussed that. The answer was 21 alpha hydroxylase. What is the least common? The answer was 3 beta hydroxydehydrogenase is the least common. Now, if it is NEETPG and AIIMS, where are we? Which type of abnormality in sexual development has best prognosis? Among this all 4 diseases, the one thing which has only hormonal imbalance, apart from that, genetically it is normal. For example, if it is a female, it will have XX. If it is a male, it will have XY. So prognosis also, it is best for CAH among these 4 sexual developmental disorders. Now, this question. Before going into the depth of this question, one request in general. Whenever you see a lengthy question, first request, don't get panicked. Every statement in that lengthy thing will have some clue for your diagnosis. So we'll look into here. 8-day-old male baby with vomiting, lethargy, and shock. If it is shock, it says only one thing. And in CAH, they are salt wasters. So if it is salt wasters, then there should be low aldosterone. Clinical examination reveals hyperpigmentation of the genitalia. That gives only one clue. There will be increase in your so-called sex steroids. Testosterone is increased. To confirm that, the further test also reveals that. Serum sodium 124. Normal, abnormal, as we know, below 135 it is called as hyponatremia. So low sodium because of low aldosterone, and naturally high potassium. Potassium more than 5 is hyperkalemia. So there is increase in potassium. Now we'll see which will be the diagnosis possible. Can this be hyperaldosteronism? Hyperaldosteronism is obviously ruled out because this presents with hypertension and increased sodium, which will not be the diagnosis. It's obviously ruled out. Can this be acute gastroenteritis with dehydration? Very well. This child can come with shock. So one possibility, it can come with shock. It could be very well AGE with dehydration. Second, can 124 sodium occur in so-called diarrhea? Very well. Sodium can be lost in the stool, so the patient can have hyponatremia. But the catch is in potassium. A patient with a diarrheal stool will lose potassium in the stools, so they have decreased potassium, not hyperkalemia. So that is also ruled out. So the answer is your congenital adrenal hyperplasia. Which variant is this? Which enzyme is deficient? As we discussed, it is the commonest variant, 21-alpha hydroxylase deficiency. Next question. Which of the following statement about 21-alpha hydroxylase deficiency is false? If you can answer this question comfortably, so far you have understood the complete discussion completely. We'll go one by one. Most common cause of CAH in children, obviously true. Affected females presents with ambiguous genitalia. Since there is excess testosterone, this is also true. Affected males presents with precox puberty. Excess testosterone, naturally there is precox puberty. Hypokalemic alkalosis, is it true? In this patient, there is no aldosterone, so sodium is lost, potassium is retained, so there will be hyperkalemia. So this statement is false. The answer, there should have been a hyperkalemic acidosis. The answer is D. A 5-year-old child presents female. The catch here is female. Female presents with virilization. When there is virilization, it indicates there is increase in your so-called sex steroids. And hypertension. When there is hypertension, it indicates there is increase in your so-called aldosterone function. With hypokalemia, what is the diagnosis? We'll go one by one. Can this be Conn syndrome? Conn syndrome is primary hyperaldosteronism. So this can have hypertension and hypokalemia. This can occur. But what is away from Conn syndrome? Virilization. Conn syndrome will not cause virilization. So Conn syndrome is ruled out. Can this be 21-alpha hydroxylase deficiency? This will present with salt-based, not hypertension. So this is also ruled out. Can this be 3-beta? As we saw, 3-beta will have all hormones are lost. This also will present with salt-based. It is ruled out. So what we are left with is 11-beta hydroxylase. That is the answer, which presents with your virilization in female child with hypertension. Next. A 5-year-old boy having precocious puberty. What should we jump into? Which is the hormone which is increased? Naturally, there will be increase in your so-called testosterone. A blood pressure of 130/80 in a 5-year-old child implies hypertension. When there is increase in blood pressure, we know there should be a hyperaldosteronic state. Which is this combination in which there is precox puberty in a male child with increase in your so-called blood pressure? We'll go one by one. Can this be due to so-called aldosterone? Aldosterone, which question is estimation of which of the following will help. Aldosterone can cause hypertension but not your precox puberty. So can this be 17-OHP? 17-OHP is increased only in a salt ester. So that is obviously ruled out. So what is the diagnosis here predominantly? There is hypertension with precox puberty. We saw the combination only one enzyme. It is 11-beta hydroxylase deficiency. If it is 11-beta, obviously we discussed regarding the biochemical marker. The biochemical marker is 11-deoxycortisol. In this paper, in your NEET 2009 exam, the toughest question many felt was this question. This was a baby girl with ambiguous genitalia found to have 21-alpha hydroxylase deficiency with salt wasting type. Which of the following karyotype would you expect? As we discussed, it is a pure hormonal imbalance, nothing to do with the genetic sex. So it is a pure normal women. It is 46XX. This question is regarding a pregnant mother. A pregnant mother presents with history of previous CAH child. What is the best management protocol in the current pregnancy? What was the discussion we made? To start the steroid, predominantly dexamethasone, as soon as you diagnose a pregnancy. So naturally, the answer becomes your B. Start dexamethasone as soon as the pregnancy is confirmed. This is the treatment for the mother with the previous baby with history of your CAH. Which of the following is used in the treatment of idiopathic CAH in infants? Naturally, you have to supplement with two hormones. One, hydrocortisone. The commonest is hydrocortisone. The next we saw, it is protocortisone. So here the answer is your hydrocortisone. If it is PGI, if questions are asked in PGI regarding CAH, we should know where we stand. Question is, which of the following is true regarding 21 alpha hydroxylase deficiency? It is multiple choice as a typical PGI question. Autosomal recessive, true. Is it a salt waster? Naturally, because there is no aldosterone, they come under salt wasters. Are they hyperkalemic? True, because less aldosterone, so more sodium is retained. When there is less aldosterone, because of this deficiency, they will lose sodium, they will retain potassium, so they have hyperkalemia. What is the last point? Metabolic alkalosis. We saw when there is no aldosterone, sodium is lost and H plus accumulates. When H plus accumulates, it is called as your acidosis. So last point is wrong here. So what are the multiple choice here? The answers are A, B and C. Now look in the bracket, and this is what we say always in our classrooms. If your basics are rock solid, brackets do not matter. Let it be PGI, let it be AIIMS, let it be JIPMER. If your basics are good, all exams can be conquered comfortably. Thanks doctors for your patient listening here. For further details, please contact this number. Thanks a lot once again for your patience. All the best.